Great. This is a case from when I was a paediatric hematologist in Newcastle. I have a slightly warped view of hematology, having trained as a paediatric hematologist, worked as an adult hematology consultant, then a paediatric hematology consultant, now working in NHSBT. So adults are just big children, and you'll kill me for saying this. Paediatrics are mostly just small adults, apart from neonates. But we can have that fight another day when we're talking about the RC Path revision course. This is a case that I felt really strongly about, and is very interesting from a transfusion management point of view as we go through it. So acute leukemia, acute lymphoblastic leukemia is still one of the commonest childhood cancers, if not the commonest childhood cancer, with a peak incidence between the 1 and 10-year-olds, and about 3.5 per 100,000 children. And survival is defined as these children walk through the door by age, their diagnosis, their disease genetics, and their response to treatment. And our current Altogether trial that we're running across the UK and beyond tries to build into all of these risk stratification factors. And now looking at most children who walk through the door with acute lymphoblastic leukemia, we have about a 96% overall survival with chemotherapy alone. And there are new agents coming along. Blinatumomab isn't less new, but still very useful. CAR T, we've still got good old stem cell transplant. And looking at the UK trials, we have a year-on-year improvement since the 1970s when we first started conducting trials. And this pattern of improvement in survival is mirrored across the world. And the St. Jude data from America is probably the best one that mirrors this completely. And that's because we've got better treatments, be it oral, intravenous, supportive therapies with transfusion, and our understanding of the genetics. So we're getting better at treating acute lymphoblastic leukemia. And this young lady that came along really challenged our thinking in Newcastle, and I haven't checked if anybody else from Newcastle is on the meeting today, so that'll be interesting to see what they think of this. So a 12-year-old young lady was transferred up from Sunderland after presenting with features of bone marrow failure. She was anemic, bleeding because of a low platelets, and had febrile neutropenia. And she had a cracking typical blood film showing acute lymphoblastic leukemia. And that was quickly confirmed by our excellent diagnostic service in Newcastle. And then when I went to speak to the family with our nurse specialist that evening, there was mum and dad and the young lady's uncle. Her uncle was there because the first thing they said before I got any words out after introducing myself was, "We are Jehovah's Witnesses." And the uncle was part of the local hospital liaison team. And they followed that, "We are Jehovah's Witnesses, and we don't want our daughter to be transfused." And that caused a small amount of horror. Luckily, I had been slightly pre-warned, but it's still something to think carefully about. So acute lymphoblastic leukemia in Jehovah's Witnesses is an interesting one, but what are Jehovah's Witnesses' views and beliefs? They're a Christian denomination founded by Charles Taze Russell in the late 19th century. They believe Armageddon is imminent, and to prevent this, they are trying to create God's kingdom on earth. They have their own Bible, the New World Translation. And as of last year, there were 9 million members in 120,000 congregations across the world. They do not celebrate Christmas, Easter, or birthdays because they feel these festivals have pagan origins. But through their New World Translation of the Holy Scriptures, there are many references to blood. From the beginning and what we would traditionally call the Old Testament in Genesis, right through to the New Testament in the Acts of the Apostles, there are many comments about why someone who follows this belief should not accept blood. From every moving animal that is alive may serve as food for you. Only flesh with its life, its blood you must not eat. And then in laying down the rules to Moses, God has said, if any man eats any sort of blood, I will set my face against the one who is eating the blood, and I will cut him off from amongst his people. For the life of flesh is in the blood, because it is the blood that makes atonement by means of the life in it. That is why I have said to the Israelites, none of you should eat blood. And again, a similar feeling from the Acts of the Apostles. So over time, since we started treating it, malignancies in children and adults, those that refuse blood products have always been carefully studied, and in the past sort of 10 years, the amount of evidence has slowly been increasing. So thinking about Jehovah's Witnesses with pediatric cancer and especially leukemia, here's some of the evidence that's out there. So they often North American, where the bulk of the congregations for Jehovah's Witnesses are. They're always small. These are rare patients. And so it can be quite challenging to gather good and meaningful data, as you'll see when I come onto my case study and comparing her course with the rest of similar patients here in Newcastle. So in 35 patients that Stevenson looked at, 60% of those patients needing transfusion support had a hematological malignancy. Makes sense. Most of what we do in paediatric hem-onc is hematology, and most of it's acute leukemia. 72% had red cells, 61% had platelets, which is quite a lot of patients having platelets, and that might be a reflection of different transfusion practices across the Atlantic. 18% of those patients, of the parents, initially declined transfusions, and in 36% of those patients, they had to go to the courts to facilitate those children being transfused. And I'm not going to go into whether that's rightly or wrongly. Another study showed that sort of 10 to 12% of all Jehovah's Witnesses will accept blood products of some sort. And so our traditional red cells, platelets, and plasma, before you start thinking of the other things that you can consider with recombinant products, tranexamic acid, or other things to reduce transfusion. If you look at outcome across all the studies that I could find on a literature review, only 40% of pediatric cases and less than a quarter of adult cases who were Jehovah's Witnesses that had conventional chemotherapy had long-term overall survival. And if you compare that to our 96% overall survival for many patients, that's pretty bad. And that's in the 11 papers that I found when I did this earlier this year. So new treatments are highly effective and can treat multiply relapsed patients who are Jehovah's Witnesses and reduce their need for transfusion support. And interestingly, those Jehovah's Witness patients who are treated without blood products have an inferior outcome to matched controls in a study done by Carson sort of 10 years or so ago. So it's a really interesting challenge walking in to tell someone they got a curable cancer, but that they did not want me to manage them in the normal way. And the family requested that we try to minimize this young lady's transfusion support as much as possible. So we talked through this in the MDT, and here's some of the feedback I got from my colleagues. You cannot get patients through ALL treatment without transfusion. As a young adult, this patient will get more symptomatic than younger patients, and therefore older patients have a higher transfusion requirement than younger and smaller ones. Everybody needs to have a red cell or platelet transfusion at some point through their leukemia treatment. And paediatric hematology teams are really good at patient blood management because of the risks of transfusion to patients and the volume of blood products we use. So hopefully a few of you are giggling hysterically at the assumptions that we made as an MDT. So we proposed in the MDT that we will give this young lady standard treatment, which was within the Altogether trial that Anne mentioned earlier. It gave her the best option for long-term cure and minimal risk of refractory disease or relapse. And looking at the evidence, if you have relapsed or refractory disease and are a Jehovah's Witness, you do not survive with your acute leukemia. And supporting this plan without some blood transfusion will be very difficult. Our normal practice sort of followed Anne's comments about hemoglobins of 70 or less, or hemoglobin falling towards 70 with concerns about symptoms, and transfusion of platelets if hemoglobin is less than 10 and not febrile, 20 if febrile, and 50 if needing a procedure, or 100 if you're bleeding or and symptomatic. So we proposed to the family and the rest of the team that we would meet with the Jehovah's Witness Hospital Liaison Team, which was the child's uncle and another member of the local congregation, and that we would try in our best manner to not transfuse this young lady, if at all possible, looking at how she was clinically, looking at her blood results, and only transfuse her if she was symptomatic with bleeding, bruising, petechiae for platelets, or symptomatic with anemia for red cells. So she's now finished a treatment successfully. And so looking back, we did a retrospective assessment of patients that were all treated on the Altogether protocol on the sort of the low risk arm regimen A, sort of induction, regimen B, induction, which does include some subtle differences. But following on from that, all the patients I included were live patients that had completed therapy by the time we looked at this data, that had the same consolidation and were randomized to the same treatment following their induction. And so it's a very small group, as you can imagine. It was 10 patients. 6 were on it, sort of induction A with Vinc, Dex, and asparaginase, and 4 were on regimen B, including this patient who was Jehovah's Witness. And we know that we risk stratify as these guys come through the front door. And then after their induction, they all received exactly the same treatment. And I've highlighted the drugs in yellow that are the ones that cause more bone marrow failure and cytotoxic reduction as risks for anemia. The split of these patients was slightly skewed to boys more than girls, and the age range was between 3 and 12. And we did not include anybody on the more intensive arms. So this really is looking at lower risk patients with acute lymphoblastic leukemia. So most were on regimen A, a few on regimen B, and then our Jehovah's Witness patient was one of the 2 older patients in this group that fits with the age distribution of the disease. If you look at the number of transfusions through treatment and when we gave them, most of our transfusions of red cells and were given in induction and consolidation 1 at the beginning of treatment. Red cells also given in delayed intensification. It says it does what it says on the tin. It's delayed and it's intensive and causes more cytopenias. And the platelet transfusions are again mostly at the beginning of therapy. And if you look at the total number of red cells, or the average number of red cells per patient, again, most were given at the beginning of treatment, and that varied by regimen. We had more patients on regimen A, so there were more being transfused. But if you look at the average number of transfusions, the guys on regimen A still seem to have, on average, more treatment at the beginning of therapy. And that seemed to be because they were younger and seemed to present with lower hemoglobins. And that is probably more to it than that. But on initial look at this data, that's what it suggested. And then as you go through treatment, the number of transfusion reduces. And interesting, in all these cases, anemia was reversible and short-lived. We didn't have any cases where the anemia became prolonged, either because of things like parvovirus that was affecting the whole of the UK at the time of data collection, or other causes like bone marrow failure from chemotherapy. So why and we're looking at sort of how we treated people differently. If you look at how we had a restricted transfusion practice in our Jehovah's Witness patient, she got 50% fewer transfusions than other patients through induction and in consolidation, and no other red cell transfusions through the rest of her treatment, whereas some other patients needed transfusion at other points. Very few patients are transfused in consolidation 2 or in maintenance, and always because of a complication, like this young man needed bronchoscopy on PICU and was bleeding. So it's interesting that by actively trying not to give blood in a restrictive way to our Jehovah's Witness patient, we could do that. But thinking about how we treated her differently and the variation in treatment on the same unit between different individuals was really interesting. So when we looked at the indications for transfusions, we were meant to be following a threshold of 70 and or symptomatic. And here are the ranges of our hemoglobin when we transfuse. So yes, we transfuse patients when their hemoglobin is very low, but we also would transfuse patients when their hemoglobin could sometimes be much higher than our threshold. If we look at when we transfused our Jehovah's Witness patients, we were often much closer to the thresholds than in some of the other patients. And if you look at the documented clinical indications rather than a full blood count hemoglobin, a large proportion of the patients were symptomatic at whatever level their hemoglobin was, especially those above the threshold of 70. And interestingly, when you look at whether a transfusion was appropriate or not, in our Jehovah's Witness patient, 1 out of her 2 transfusions was given on a Friday with a documented reason in case she became anemic and needed one over the weekend. So in a patient and a family who had asked that we only transfuse if she really needed, 1 of her transfusions could have been avoided. 5 of her transfusions, the indication was looked pale, with a hemoglobin range between 52 and 87. And the other sort of 12-year-old patient who had a hemoglobin of 87 was pale but completely asymptomatic in all other respects and had a hemoglobin of 87. And interestingly, if you look at the data, sort of a hemoglobin of less than 55 increases your risk of silent strokes and cerebral infarcts. This is really important in patients with sickle cell disease, but also relevant in children who have other causes and a sudden drop in anemia. And if you look at this threshold of 55, only 6 of the 38 transfusions we gave to all these patients was below 55. Following the start of treatment. So was there a cost associated with this treatment? We know cost equals money, but also cost equals side effects or adverse events. 1 transfusion, a lad on ICU, caused urticaria and wheeze. Was it related to his neutropenic sepsis and stay on ICU, or was it the blood transfusion? We'll never know, but it could have been. So there are risks to transfusion, and we know that. And Anne pointed out the overrepresentation of paediatrics in shots, and we've got to take that into consideration when we're thinking about transfusion in children. Of the 61 red cell unit transfusions given, that equated to 63 different units exposed to these patients. And that on today's cost is about £11,500. The platelets, 28 transfusions, just over £7,000. If you take that sort of threshold of 55, or say the symptomatic patients with the hemoglobin above 60, we could have avoided transfusion over half of those red cell units. That would have been about a saving of £5,500–6,000, and that's just in 10 patients over an 18-month period in 1 single unit. And if you think about that rolled out across the UK, there's potential reduction of risk and reduction in cost, and especially that's fairly important with us having fairly ropey blood supplies for some blood groups at the moment. So when we looked through this and have thought about this, we know that ALL has a fantastic survival, 96% overall survival with chemotherapy alone. However, if you look at those who are Jehovah's Witnesses or declined blood products, that drops to 40% in the paediatric cases that I could find in the literature. Transfusions are usually given through induction, first consolidation, and delayed intensification when you're on cytoreductive chemotherapy. And the anemia that causes is nearly always short-lived. Our Jehovah's Witness needed 2 transfusions in total. Only one of those was probably really needed. So can we get patients through acute leukemia therapy without many transfusions? Yes. Could we do it without any transfusions? Possibly. And I'll come back to that in just a second. Restricted transfusion fraction does work, and it seems safe. She was fine, but she was a very motivated and some would say potentially precocious young lady, but she was an amazing patient with an amazing family who really challenged how we were doing things and asked questions about why, which I think is always really useful. We could potentially lower our transfusion threshold below 60, though Anne may have a view on that with the recent guidelines that are being pushed through. But we've got to consider other risks of that anemia, especially with things like thrombocytopenia, other medical problems and symptoms. We could save money. And I do have an MBA, so I do think about business and cash. And I think it's really interesting how the complex system of patient management and of hospital care in the UK is very interesting. And there is a suggestion that actually consideration of patients who decline blood products for alternative therapies like blinatumomab up front, like we might do for other high-risk patients, like those with Down syndrome, might be a better and safer option to minimize their exposure to cytoreductive chemotherapy and low hemoglobin anemia and blood product exposure. So one thing I haven't added in here, which is a mistake, is what else can you do to minimize someone's need for transfusion through ALL therapy? All the American studies talk about anything from erythropoietin, and I've used that very successfully in non-malignant patients, including neonates, who are Jehovah's Witnesses, to avoid the need for blood transfusion across the age ranges, and that works well. It might work a little bit better if you add GCSF. It might work a little bit better if you add intravenous iron, B12 and folate supplementation. So all of these things should be considered. And if I was to do this all again, I would follow sort of good and normal patient blood management policies of optimizing a hemoglobin with anything that you can. And in this situation with recurrent courses of chemotherapy, I would not be concerned about the risks of erythropoietin, such as polycythemia, and that we might be worried about in older patients. And even in neonates, that does not seem to be a problem. I think we need to be very careful about how we define someone as being symptomatic, and looking pale and being tired are clearly not related to your hemoglobin. And we can fight over transfusion thresholds till the cows come home. What can we do next? I would love to have looked at this in a more detailed way across the UK, and any of the registrars involved in HemeStar. It might be useful to have a chat about this if this is something that people were interested in. And maybe we need to think about transfusion being part of or future trials or added into it.